Hello everyone, my name is Alyssa Chang, and I will be presenting a case report titled Chronotropic Incompetence, Atrial Fibrillation with Slow Ventricular Response with Hemodynamic Instability. The co-author for this case report is Dr. Ivan Ko. Neither of us have any relevant financial relationships, and therefore there are no financial disclosures. To begin, atrial fibrillation with slow ventricular response, SVR, which is a heart rate less than 60 beats per minute, BPM, is often due to atrioventricular, AV, nodal blocking medications, concurrent AV heart block, acute inferior myocardial infarction, hypothermia, or distal sinus node dysfunction. We present a case of symptomatic atrial fibrillation with SVR requiring permanent pacemaker placement, PCM. Regarding the case description, a 68-year-old male with a history of atrial fibrillation with SVR, type 1 diabetes mellitus complicated by end-stage renal disease requiring hemodialysis, and peripheral artery disease with bilateral below-the-knee amputations complicated by recurrent wound infections, presented for hypotension and altered mental status concerning for sepsis. He was found to have bacteremia translocated from his lower extremity wounds, and he was placed on broad-spectrum antibiotics. He was transferred to the intensive care unit for shock requiring vasopressors and acute hypoxic respiratory failure in the setting of hypervolemia because of his inability to tolerate hemodialysis. Initial blood pressure was 70/37 millimeters of mercury, heart rate 40 to 50 BPM, and a venous blood gas with a lactate of 5.4. Electrocardiogram without concern for heart block or acute ischemia. No recent administration of AV nodal blocking agents. After initiation of norepinephrine at 0.1 micrograms per kilogram per minute, blood pressure improved to 195/76 millimeters of mercury. Heart rate was 61 BPM, and the lactate downtrended to 3.7. With discontinuation of norepinephrine, heart rate and blood pressure decreased, followed by an increase in lactate and subsequent disorientation. On to the discussion. Given that the patient was on the appropriate antibiotics for his bacteremia, there was low concern for sepsis as the cause of his recurrent shock. Due to the trend of worsening bradycardia preceding hypotension, which rapidly resolved with low-dose vasopressor, there was concern for hypotension due to chronotropic incompetence. This theory was tested and confirmed by an improved lactate after starting low-dose norepinephrine for its beta-1 receptor agonist effect. This led to the placement of a transvenous pacemaker, TVP, on VVI mode set to 80. After TVP placement, he was able to maintain his mean arterial pressure, his lactic acid cleared, and he was able to undergo hemodialysis with ultrafiltration. As a result, the patient underwent PCM by the electrophysiology team with controlled hemodynamics. Overall, hemodynamic instability in the setting of atrial fibrillation with SVR can be evaluated with placement of a TVP and definitively managed with PCM. It has been reported that atrial fibrillation with SVR may require PCM to prevent symptomatic bradycardia, but recent literature reviews on this topic are lacking and thus warrants revisitation. Thank you for listening.